My name is Sachin. I'm one of the nurse practitioner students, and I'm here to do a cardiovascular exam on you today. Okay. So this video will be recorded and published on YouTube. May I have your permission for that?
Yes.
Okay. May I have your first and last name?
Sajid Singh.
Sajid Singh. Okay. So I've already washed my hands. I'm going to begin assessment now. Okay. So the first thing I would do is to check a patient's blood pressure, supine as well as sitting and standing, and just to see any abnormalities there. I will do it on both arms. There shouldn't be much of a difference in both arms, but if there is, then that needs further investigation. Second thing that I'm going to assess is called a jugular venous distension pulse. And Rena, what I'm going to have you do is just come close over here just so you can see. Okay. And so he is at a 30-degree angle. JVD in a patient that is volume down or hypovolemic, you may have to have the patient lay supine to have the jugular distend a little bit. Now, on the other hand, if the patient is hypervolemic or a congestive heart failure and fluid overloaded, you may in fact have the patient sit upright to have that jugular vein distended. In Mr. Singh's case, he is a young, healthy gentleman, so we shouldn't have an issue. So I have him at approximately 30 degrees, or yeah, about 30 degrees or so. So I'm going to have you come close. So Mr. Singh, I'm going to have you look to your left side, okay? So what I have here, this here is the sternocleidomastoid mastoid muscle. It has two attachments at the end. You have the one that goes to the manubrium, and you have one that goes to the clavicle. The external jugular vein, actually, it comes laterally to the sternocleidomastoid muscle, and it comes and attaches to the subclavian vein. The subclavian vein goes and becomes the brachiocephalic vein and goes to the right atrium. On the other hand, the internal jugular vein is more medial to the sternocleidomastoid muscle. And then medial to that, you have the carotid artery. So to measure the jugular venous distension, there is a little bit of anatomy that we need to know. Here you have the sternal notch, and this portion, the top portion of the sternum, is called the manubrium. And this manubrium attaches to the body of the sternum at a spot that's called the angle of Lewis. This angle of Lewis, which usually I can feel a bump there. You have the suprasternal notch, and as you come along, the first bump that you feel, that is the angle of Lewis. Right adjacent to the angle of Lewis is the second rib. Right below that second rib is the second intercostal space. So to measure a JVD, what I would do is to have a vertical ruler. So I have a ruler on this card here. To have a vertical ruler right at the angle of Lewis. And then I would have, so in Mr. Singh's case, very, very, very light pulse, but it's more so towards the end there. So I would measure that. That's less than 2 centimeters, which is a normal finding. Now, I'll go more medially to feel the carotid pulse. So Mr. Singh, you're going to feel pressure here, okay? I'm going to feel for your carotid pulse. Okay. So the carotid pulse, you want to feel it one side at a time, because if you occlude both carotids bilaterally, you may induce a syncope, and we don't want that. So what I'll do is I'll just listen to the carotid pulse here. The carotid pulse is a brisk upstroke for me when I felt Mr. Singh's carotid pulse with a gradual down downstroke as well. And it felt strong to me. It felt about, I would say 2 out of 4. So now I'm going to listen to the carotid for any bruit. Okay, now I'll use the bell. So Mr. Singh, I'm going to have you turn this way also. So I'm going to feel for your carotid first. Okay. Once again, the left carotid pulse is it's a strong pulse on palpation. It has a brisk upstroke and a gradual downstroke. So I'll grade that pulse 2 out of 4. Now I'm going to listen to that carotid with the diaphragm of my stethoscope for any bruits or thrills. Okay, which I don't hear at all. Now the bell. And I don't hear any bruits or thrills. With Mr. Singh laying that way, since he's already laying there, what I'll also do at this time is I would check his digits. It's all his extremities, since he's already laying there and comfortable. I will check the cap refill on every digit, which is less than 3 seconds. I'll do it on here as well. Okay, extremity is warm. Did I miss your thumb on this side? Okay, alright. Now we're going to go down to these toes. Okay. All less than 3 seconds. And the extremity is warmly touched, which tells me that there's good perfusion there. And also hair distribution is good as well bilaterally, which also tells me that there's a good arterial perfusion. Now what I'm going to do is I'm going to start off by visually inspecting his anterior thorax. Just for clarification, I did manage to have him wear a vest, but he doesn't want to be fully exposed for the examination. However, I will verbalize the spots that I'm checking. So I will visually inspect the chest area for any visual palpable lifts or heaves or thrills. And the place I will check is the second intercostal space on the right sternal border. So the way I find that is I find the angle of Lewis, and once I find that angle of Lewis, right adjacent to that is the second rib. Right underneath that rib is the second intercostal space. And then same here, find the angle of Lewis, right adjacent to the on the left side is the second rib, and right underneath that is a second intercostal space. And Erb's point would be third intercostal space, which is down here. And then I would go to the tricuspid, which is the lower sternal border of the left side, which is approximately a fourth intercostal space. That will be the tricuspid. The mitral valve is at the fifth intercostal space, mid-clavicular line. And what I'm doing for right now is visually inspecting those areas for any lifts or heaves, and which I don't see. Now I'm going to move on to the palpation. So what I'll have Mr. Singh do is kind of turn on his left side. Just so you can expose this chest here. If you want to go like this way, okay. So usually what that does is it puts the left ventricle more closer to the chest wall. It's easier to palpate that left ventricle. So what I'll do is the mid-clavicular line, and at the fifth intercostal space, and I'll feel for the PMI, point of maximal impulse. And I feel that. I feel the point of maximal impulse. And I'm going to palpate at the tricuspid, which is the fourth intercostal space, left lower sternal border, Erb's point, second intercostal space, on the left side, and then second intercostal space on the right side at the right sternal border. Are you having any pain there, Mr. Singh?
No.
No. Okay. Since he's already laying there on his left side lateral recumbent position, I'm just going to listen to his mitral valve with the bell first. So I'll listen to the fifth intercostal space with the bell first for any murmurs or regurgitation. Usually, with a bell, you would hear if he has mitral stenosis, which I don't hear. I hear S1 and S2. So now, Mr. Singh, what I'll have you do is I'll have you sit up for me. All right. So now I'm going to listen. I'm going to listen to his those places that I have mentioned before, and I will listen with the bell, and I will also listen with the diaphragm. So we will start with the suprasternal notch down to the first bump. That's the angle of the Lewis. To the right is the second rib. Right below that is the second intercostal space. So listen with the diaphragm first. Second intercostal space, left sternal border. Erb's point, third intercostal space on the left side. Tricuspid, fourth intercostal space, left lower sternal border. Mitral valve at the fifth intercostal space, mid-clavicular line. Now I would come back with the bell. Erb's point. Below that, I have just listened to the tricuspid, which is the fourth intercostal space, left lower sternal border. Erb's point, third intercostal space on the left side. Pulmonic area is on the left side of the second intercostal space, left sternal border. And the aortic is on the right side, second intercostal space, right sternal border. Now, I do not hear any murmurs. I hear the S1, which is the closure of the tricuspid and mitral valve, and I hear the S2, which is the closure of the aortic and pulmonic valve. I do not hear any murmurs, which may suggest a regurgitation or a stenotic valve. While I'm at it, I'm going to listen to the splitting, the physiological splitting of S2, which is best heard on the left lower sternal border or the Erb's point at the third intercostal space on the left side. Physiological splitting of S2 usually results, is best heard during late end inspiration. And what actually happens is when you take in a deep breath, the diaphragm descends. You have a increased negative intrathoracic pressure. And when that happens, you have an increase in venous return to the right side of the heart. You have increased right ventricular filling, and that tends to delay the closure of the pulmonic valve. So what I have Mr. Singh do is take in a deep breath and hold it. Okay, so let me just anatomical landmarks here. So angle here, okay, bump there. That's the second, so I'll go to the third. All right, Mr. Singh, taking a deep breath and hold it. Yep, go ahead and take it. You can resume your breathing. You're going to do one more time, taking a deep breath and hold it. Okay. So, okay, you can breathe normally now. So with the diaphragm, I did hear the splitting of the S2. The aortic will close initially, followed by the pulmonic valve, which is a slight delay there, which is a normal physiological finding in a normal, healthy person. now with Mr. Singh sitting there, what I'm going to do is I'm going to have him lean forward. And what that does, it does bring the left ventricle more closer to the chest wall. With expiration, you can hear the aortic regurgitation more with expiration. So I'm going to have Mr. Singh just lean forward for me a little bit here. Okay. So what I'm going to have you do, Mr. Singh, is taking a deep breath and you're going to hold it, okay? And now breathe out, and hold it there. Okay. You can breathe normal now. I'm going to listen to aortic and pulmonic again, so go ahead and take in a deep breath, exhale all the way out and hold it. Okay, you can breathe normally. So I don't hear any murmurs. So just for clarification, aortic valve is at the second intercostal space, right sternal border. That's where I heard at. Pulmonic is at the left intercostal space, second intercostal space in the left sternal border. Herbs is at third. Tricuspid is at the fourth or the left lower sternal border, and the mitral is at the fifth intercostal space, mid-clavicular line. Okay. Now what I'll have, just kind of feel your pulse. I'm going to feel with the radial first. Good. Brachial. Good. All right. What I'm going to have you do, Mr. Singh, is lay flat. You can lay flat here. I'm just going to put your stomach. So the radial and brachial pulses were both 2 out of 4, which is expected normal. Okay. So the abdominal assessment, you have the aorta that comes down. Right at approximately the point of the umbilicus, it divides into the internal and external iliac artery. The external iliac artery further goes down to your legs, and as soon as the external iliac artery crosses the inguinal ligament, it becomes femoral artery. Same artery, just different names depending on where it crosses. So when it crosses the inguinal ligament, it becomes the femoral artery. Above the umbilicus, you have the renal artery, which branches off from the aorta on both sides. So what I would do, I would inspect Mr. Singh's abdomen first for any obvious pulsations or any lifts or anything like that. And I don't see any. And now what I'm going to do is I'm going to listen over the epigastrium at the aorta for any kind of thrills or bruit, which I don't hear anything. And at the renal arteries, bifurcation here, external artery, and I would now listen to the femoral artery. Okay, I'm going to listen to the femoral artery. Now I'm going to feel his femoral artery, or palpate, and I'm going to listen to his femoral artery on this other side, and I'm going to palpate his femoral artery. So bilateral strong 2 out of 4 femoral artery pulsation. Now I'm going to reverse it with a bell. So femoral artery with a bell. Okay, on this side here. Okay, The iliacs come up, they merge into one aorta. So I'll listen to the renal side. And I'll listen to the aorta at the epigastrium. And which I don't hear at all. Are you having any pain at all?
No.
No pain. Okay. All right. So now I would complete the rest of my pulse check. I've already done radial brachial bilateral carotid. Now what I'm going to do is palpate the popliteal artery, which is back here. Okay, that's 2 out of 4, expected normal. Posterior tibialis pulse is right here, so I'm gonna feel that. That's 2 out of 4. Here, 2 out of 4. Posterior tibialis pulse here as well. 2 out of 4. 2 out of 4. And the popliteal pulse. 2 out of 4. Once again, extremity is warm to touch. Good distribution of hair, which indicates a competent arterial perfusion. Good posterior tibialis and pedal pulses. I've already done the capillary fill on all digits. They're all less than 3 seconds, as well as the digits up here. Femoral pulses are 2 out of 4. Bilateral carotid are 2 out of 4. Bilateral brachial is 2 out of 4. I just want to mention during inspection, sometimes patients can have a concave chest wall, which is known as pectus excavatum. Sometimes that can displace the PMI more laterally just because you don't have enough space. Also, some patients may have pectus carinatum, which is kind of like a pigeon pigeon type chest, which is the costal cartilage supposedly grows quicker than the rest of the ribs. So, Mr. Singh, you're welcome to sit up now. Okay. I am done with my assessment.
Thank you.
Do you have any questions?
No questions.
Okay.
Thank you.
Thank you so much.
Thank you.
All right.